Esophageal Atresia. Everything you need to know for you and your baby. EA is a birth defect that affects every 1 in 2,500 to 4,500 live births. The esophagus is the tube that connects your mouth to your stomach, and atresia refers to the absence or abnormal narrowing of a tube in the body. In the case of EA, the upper portion of the esophagus does not connect to the lower portion, which results in food being unable to pass from the mouth to the stomach. There are 4 main types of EA, and they vary depending on the presence of a tracheoesophageal fistula. A fistula is an abnormal connection between 2 tubular organs. In this case, there is an abnormal connection with the trachea, the breathing tube, and the esophagus. Type A is EA without the presence of a tracheoesophageal fistula. The upper portion of the esophagus simply does not connect to the lower portion. Type B is EA with a tracheoesophageal fistula at the upper portion of the esophagus. The upper portion of the esophagus connects to the trachea, which would allow food to pass into the lungs. Type C is the most common, with a tracheoesophageal fistula at the lower portion of the esophagus, which would allow air to pass into the stomach. Type D is EA with tracheoesophageal fistulas at both the upper and lower portions of the esophagus. The development and causes of this disease are still being investigated, but it begins with the development of the gut tube during the 4th week of embryo development. The middle layer of cells in a developing embryo is known as the mesoderm. During normal development, a wedge in the mesoderm, called the tracheoesophageal septum, separates the developing esophagus from the trachea. Esophageal atresia is caused when there is a defect in the differentiation of the mesoderm, and there is a failure in the separation of the trachea and esophagus. The diagnosis of EA is typically made in the first 24 hours of life. However, some signs can be detected during pregnancy. An ultrasound may indicate polyhydramnios, a condition where the fetus is unable to swallow amniotic fluid. The absence of a gastric bubble indicating air in the stomach is also a prediction of EA. However, features of EA are rarely observed in fetuses on prenatal scans. In the delivery room, the symptoms present are excessive secretions or foaming at the mouth. The baby may also have aspiration pneumonia or gastric distension, depending on the type of EA. A confirmed diagnosis will be made if a feeding tube is unable to pass from mouth to stomach, indicating that the esophagus is not continuous. A chest X-ray will show an esophageal pouch and a gastric bubble. Pre-surgery, a series of tests will be done to identify the risks and any associated congenital abnormalities. A continuous suction of secretions will be done to help facilitate breathing, and it is extremely important that the baby is not fed orally to prevent food from passing into the lungs. Primary correction of EA is to connect the 2 parts of the esophagus. Transitioning to a normal diet occurs 2 to 3 days after surgery, and radiological exams will be done 1 week after surgery to identify complications. There is an overall good prognosis with this congenital disease, but surgical complications need to be managed, and associated congenital abnormalities will require continual management throughout life.